Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This podcast provides observations and commentary on the JCO article Adjuvant Chemotherapy for Stage 2 Colon Cancer with Poor Prognostic Features by Aaron S. O'Connor et al. My name is Dr. Leonard Saltz, and I am the head of the Colorectal Oncology section in the Department of Medicine at Memorial Sloan Kettering Cancer Center in New York City. My oncologic specialty is gastrointestinal oncology. Then I am recording podcasts for high-risk Stage 2 colon cancer. What is the role of adjuvant chemotherapy? Today's date is May 21, 2011. The NCI Intergroup Trial 0035, first reported in 1989, demonstrated approximately a one-third risk reduction in the chance of death from colon cancer for those Stage 3 patients given 5-FU-based chemotherapy. For those patients on the trial with Stage 2 disease, however, the chance of being alive at 7 years out from operation was an identical 72% whether they had received chemotherapy or not. Similar results were found in other trials. In this context, investigators began looking for ways to stratify Stage 2 patients into higher and lower risk groups, with the intention that high-risk groups would be treated, while low-risk groups would either be observed or treated less aggressively. However, intrinsic to this concept is the notion that a patient who is at higher risk for recurrence is more likely to benefit from adjuvant chemotherapy. To understand the potential problem here, we need to consider the concept of prognostic versus predictive indicators. A prognostic indicator gives us information about what is likely to happen, independent of our intervening. It defines a group in which an event, such as the development of metastatic cancer, is more or less likely to occur. A predictive indicator tells us who is more or less likely to benefit from a treatment or intervention. It can potentially tell us who to treat and who not to. Herein lies the crux of the matter. Prognostic markers are not necessarily predictive, and therefore are often not really very useful. They may give the clinician a comfort or discomfort level, but they don't provide actionable information. A predictive marker does. With this background, let's return to what the O'Connor paper contributes to the discussion of Stage 2 colon cancer. Having failed to convincingly demonstrate that chemotherapy had the power to help the Stage 2 population as a whole, investigators looked for clues as to which patients might be identified as high risk for failure, and so might be the ones most likely to show a benefit from chemotherapy. This has led to the widely held, although not directly tested, hypothesis that high-risk Stage 2 patients should be treated with adjuvant therapy, while good-risk patients should either be observed or treated less aggressively. O'Connor et al. Present data that challenge this assumption. They analyzed the linked SEER Medicare databases to assess the outcomes in a large number of patients treated in a non-study setting. This is not the same as a prospective randomized trial and should not be interpreted as such, but it is nevertheless a tool that can provide useful information. Their numbers are large, and the assumption of the study is simple. If adjuvant chemotherapy is of benefit to a particular group, then patients within that group who received adjuvant chemotherapy should have had a better outcome than those that did not. Indeed, that is what was seen in the 18,185 Stage 3 patients, that 57% of Stage 3 patients who received chemotherapy had a superior chance of being alive at 5 years out than did the Stage 3 patients who did not receive chemotherapy. The hazard ratio was 0.64, and the p-value was less than 0.001. While it is concerning that 43% of Stage 3 patients never received adjuvant chemotherapy, a topic for discussion on another day, this outcome supports the validity of the SEER Medicare analysis Critically then, since clinical trials have, for the most part, failed to demonstrate a survival benefit for adjuvant chemotherapy in good risk stage 2 patients, we might expect the outcome in Medicare patients who have and have not received chemotherapy to be the same. And in fact, that is what O'Connor et al. Reported. The chance of being alive at 5 years was the same for the chemotherapy and non-chemotherapy groups, with a hazard ratio of 1.02 and a p-value of 0.8. However, given the increased risk of death in stage 2 patients with poor prognostic factors, we might have expected O'Connor et al. To see an improved outcome in those with high-risk stage 2 who received chemotherapy, just as they saw in stage 3 patients. But they did not. In their analysis, which included 18,613 patients with high-risk stage 2, when adjusted for covariates and comorbidities, the survival was the same in those who received adjuvant chemotherapy and the group that did not. The data presented by O'Connor et al. Do not support the hypothesis that adjuvant therapy is appropriate for high-risk stage 2 disease. Interestingly, this paradigm appears not to have been adopted by the practicing community at large, as their data show no evidence of use of risk stratification to determine use of therapy in stage 2 patients in actual practice. In fact, these data argue against the use of adjuvant therapy in either good risk or high risk stage 2 patients, at least within the Medicare age range. As a retrospective, non-randomized report, these data are not sufficiently powerful to settle the argument. They do constitute a strong addition to the arguments against the routine use of adjuvant therapy in stage 2 patients, and argue against the use of current risk stratification factors for guidance in that decision-making process. What they perhaps most reinforce is that a prognostic marker is not necessarily predictive, and that just because a patient has a poor prognosis does not necessarily mean that we can improve that prognosis by treating with chemotherapy. There are potential flaws in the O'Connor trial. The use of emergency hospitalization as a high-risk factor is not standard, and other risk factors such as lymphovascular invasion or perineural invasion could not be assessed. Much of the data accrued before the availability of oxaliplatin. Microsatellite instability, a factor with substantial prognostic and possibly predictive power, could not be assessed. Nevertheless, the large retrospective data set of O'Connor et al. Argue that perhaps our assumptions about the predictive nature of high-risk factors in stage 2 colon cancer are not correct. Does this mean that patients with stage 2 colon cancer with high-risk features should not be offered adjuvant chemotherapy? No. It means that the conclusion of the ASCO consensus panel of 2005 remains valid. Stage 2 colon cancer is a complicated, inadequately understood entity with complex and conflicting data. Patients deserve a consultation with a medical oncologist to review the data and their options. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.